Mayo Clinic presents
Emergency Medicine Grand Rounds.
Welcome to Always On EM, the Grand Rounds edition for September 2024. My name is Venk Bellamkonda. I'm one of the hosts of the show. The American College of Emergency Physicians is hosting its annual scientific assembly in Las Vegas, Nevada at the end of September, and I will be traveling there. Maybe you will be too. So please email the show at alwaysonem@gmail.com, and maybe we can sit down and it'd be fun to catch up and hear your stories instead of you having to listen to mine. Also, recently, Dr. Britt Long traveled here to Rochester along with his family, and our faculty and I got to sit down and get to know him a little bit more. He's really an outstanding individual, and he hosts a wonderful podcast called the EM Docs Podcast. It's a fantastic way to get quick, digestible content relatable to day-to-day practice, and if you aren't familiar, I'd love for you to go check it out. I hate to break with tradition, so I'm going to take a moment to ask you to like, comment, and follow the show on whatever platform you're using, as well as please tell your colleagues and friends about our show because many people still aren't familiar with what we offer. And you are the best to be able to explain what value we bring to your life and how this might be able to make their life a little bit better. Without further delay, let me get you to the recording from a recent Grand Rounds on a topic called INOCA. Maybe it's new to you, maybe you know a little bit. Either way, you're going to get a lot out of this. You're going to hear me give the formal introduction of our speaker right now. I'm really excited about our guest today and our topic. It's one I'm not personally very familiar with, and it was brought to us by Dr. Molly Jeffrey. She had heard Dr. Shah speak and reached out to me to suggest that he's amazing and we should invite him to share his thoughts with us. And so I'm really excited to introduce Dr. Shah to you all. Dr. Shah is an interventional cardiologist who specializes in the invasive evaluation of coronary artery disease, coronary physiology, and complex coronary interventions. He was an undergraduate at Pennsylvania State University and went to medical school at the University of Illinois College of Medicine, where he graduated with an MD as well as a PhD in neuroscience. He subsequently completed his internship and residency in internal medicine at Yale New Haven Hospital, followed by clinical fellowships in cardiovascular medicine, peripheral vascular interventions, and interventional cardiology. Dr. Shah has received numerous honors for patient care and education, including the Dr. Linda Rosenfeld Cardiology Fellowship Teacher of the Year Award, Wendy Yu and Thomas C. Naratil Pioneer Award, the Veterans Administration Eye Care Award, and Yale's Internal Medicine Excellence in Outpatient Care Award. In 2023, he was recognized by the Society of Cardiovascular Angiography and Interventions, or SCAI, as one of the 30 in their 30s award recipients for professional excellence in interventional cardiology. His scholarly work has focused on the outcomes of cardiovascular interventions and the invasive assessment of coronary physiology. He is a national co-principal co-PI for the Discover INOCA multi-center registry and has active research projects at Yale regarding the diagnostic yield of invasive coronary physiology testing, ischemic heart disease in women, and the vascular effects of psychological stress. And so for all these reasons, I'm really excited to hear about ischemic and non-obstructive coronary artery disease. And thank you so much, Dr. Shah, for joining us.
Thank you, Dr. Bellamkonda, for the kind introduction, and it's really nice to be joining you all today virtually. My topic might be new to some of you, and I've tailored this talk to be suitable for an emergency medicine audience, but please chime in if you have questions or comments at any point. So my title is Seeing the Invisible, Ischemia and Non-Obstructive Coronary Arteries. My disclosures are essentially research funding and then off-label use of a medication called acetylcholine chloride. So I'm going to break the talk up into three parts, and all three of them focus on this central question of how can we improve the way that we diagnose and treat ischemic heart disease, which is something that all of us take care of in many ways. So you see it from your standpoint in the emergency department, and I see it as a cardiologist. So the first section is background, and then I'll move on to innovations and progress. The key background here is that every year, 10 million patients are evaluated for chest pain in the United States. 20 to 40% of all people will have chest pain that makes them seek medical attention at some point in their lives. It's one of the most common complaints in the emergency department, and you all live through this. Interestingly, if you look at the 7 million people who present to the emergency department with chest pain every year, it's more likely to be women than men. And we know that determining the cause of chest pain is essential because it can be a symptom of a lack of blood flow to the heart, among other things. And so you need to know what it is and what it isn't. It can be a stable symptom or a sign of a heart attack. And so that's why sometimes time is of the essence. And importantly, from my standpoint, cardiovascular disease is the leading cause of death in women and men. And so often we need to make sure that we have a diagnosis right so we can appropriately treat patients. So why does this matter to you, especially in emergency medicine? Why are we talking about this topic today? So I have three points that I want to make up front. The initial evaluation of new onset cardiac symptoms like chest pain or shortness of breath is often performed by emergency medicine. So as a field, you are essential for this topic that I'm talking about today. Patients looked at emergency medicine providers as a key source of information and guidance. And so it puts you on a pedestal in a way, because often you're the first point of medical contact where people will get information. And then finally, downstream care depends on the initial evaluation and assessment. And so often the words that you use in the emergency department will shape what happens to the patient down the line. The key symptom that I'm going to be talking about today is chest pain. And, there's other symptoms that fall into this category of angina. But if you just look at this phrase of chest pain and you do a Google Trends search, this is not a medical search per se, but this is kind of a nice way to look at prevalence. More people are searching for the words chest pain now than they ever have. And the way that Google Trends work is that this is an index search. And so it's relative search volume. And so starting when Google originated in 2004, you can see that the amount of search volumes has been increasing steadily. It peaked during the height of the pandemic, but it has not cooled off. It's still continuing to rise. And this is something that we don't totally understand. But during the same time period, the number of coronary vascularization procedures like stents, which is what I do, or bypass surgery, has either stayed flat or decreased. And so there's an increasing burden of people searching for chest pain that aren't being revascularized. So this is a central statement that I want to make, which is every day people around the world seek medical attention for symptoms of heart disease, such as chest pain or shortness of breath, only to be dismissed or told that routine testing did not show any problems with their heart. I know that this is something that all of you have experienced at some point, and really it's central to what we're going to be talking about next. I'll show a case to set the stage for the rest of the presentation. And so I show this picture, which is a piece of art that this patient made. She was a professional, has at this point had a son in medical school, and is really a very sharp person. And I just want to show you what happened to her. And so I'll let her speak in her own words a little bit. So this is Laura, and this is her story.
I had difficulty getting to sleep that night. I remember curling up kind of in fetal position and finally got to sleep. And the next morning I woke up early and I said, I'm just going to get up and do something for myself. And I'll go do my, little boot camp workout in the basement. It was pre-dawn, so I was glad I was out running. And came up from my workout. I pulled off. That burning sensation was coming back. I said, maybe I just need to eat something. I tried to eat a small bowl of cereal, and I couldn't. I had to dump it down the drain, and I was going to make my way upstairs to take a shower, and my chest exploded. I had sharp substernal pain and just explosion of deeper pain across my chest, radiating both sides. And I said to my husband, could you Google, fortunately he was home, could you Google heart attack in women? I said, I don't know where I'm going, if I'm going to the hospital today or to work, but I need a shower. So I went upstairs, foolishly, took a shower, and I said, do we have some baby aspirin in the house? And he found an old bottle, probably expired, and I took a handful of those, and I hesitated to take that too, because I still had that burning, but within 20 minutes, we were on our way to the hospital and my pain was subsiding. And I walked into the emergency room and parked the car. And I said, I was having some chest pain, and then I got to talking to the attending physician and he says probably something UA. And I heard that repeatedly from him. And there were 2 troponin tests and both were negative. And then they were going to move me to another room, and I could walk there. Said I could walk, and they said they were going to put me on a treadmill. And by the time I got to that other room, that feeling was coming back. It wasn't totally responding to the nitro they were giving me in the hospital, and that's when they told me I had a heart attack and they transferred me. But I guess I didn't recognize any of those symptoms. It never occurred to me that I would have a heart attack or have any kind of heart condition.
So you've all seen this story and you've seen patients come in like this, and what happens next is also kind of straight out of the playbook.
I had difficulty getting to sleep.
So Laura gets rolled into the cath lab because when somebody has this kind of syndrome, and that's what we're suspecting, we're really set up to do this. So she has a coronary angiogram, and this is kind of what my day job looks like, where we do a fluoroscopic procedure, inject contrast dye into the coronary arteries of the heart, and we can identify blockages that might be restricting blood flow to the heart. So this is Laura's angiogram, and so these are some still images of the films. This was done in an outside hospital, and what she was described as having was this critical narrowing of her left anterior descending artery. This is kind of the normal appearance of coronary arteries, and then right here in the middle, it's a different appearance to the vessel. And so based on that, the operator put 2 stents in, and it upstairs to recovery, but throughout the night kept having more episodes of chest pain. And so that the following morning was brought back down for what we call a reshoot. They made sure that the stents were open and everything looked great. So they discharged her from the hospital. She unfortunately kept having ongoing symptoms after this. And then a year later, saw a second evaluation. So she went up to a major academic medical center in Boston. The angiogram at that time looks very much the same, where her stents are wide open. So they did an intravascular ultrasound of the blood vessel, and based on that, they described a kink in the blood vessel up here. And so this word of kink it's a non-anatomic term, but they weren't sure what to do with it. And so they actually referred her for bypass surgery. So she was turned down for surgery in Boston because she was otherwise a fit and relatively well person, but just having these excruciating episodes of chest pain. So then she came back locally and was actually able to get bypass surgery. So she got a single vessel coronary artery bypass to that same blood vessel. And so that was in 2013. She got a Lima to LAD and does well for 2 years. And then in 2015, she returns, again, has more episodes of chest pain, additional emergency department visits, and then ends up back in the cath lab. So now her angiogram looks a little bit different. This is her left anterior descending here, and then this is where the native vessel is, and this kink or this narrowing that you see at the bottom is where the bypass graft anastomosed. And so they said that this was an anastomotic failure of the bypass graft, and so they put a third stent. So now the blood vessel looks good again. And so had temporary relief, but then her symptoms returned right after. So from 2011 to 2022, so when her symptoms started until the year before I met her, she had 9 stress tests, 5 cardiac catheterizations, 3 stents, and 1 open heart surgery. But her symptoms did not stop and really remained exactly the same throughout that time period, despite these really intensive interventions. So here was the chart note before I met her. And so it says she continues to have atypical symptoms, though this may have recently improved. To err on the side of safety, I offered a repeat cardiac catheterization, which she has had numerous times in the past, though she declines for now, which I actually think on her part was pretty smart because she had not benefited from these prior interventions. So a year later, she comes in with escalating symptoms, and then at that point, there was some awareness of the work that we were doing, and so she gets sent in for what we do, which is a coronary physiology study where we try to understand what's happening in the patient's blood vessels, which could give them these symptoms. So here's her angiogram, and then again, the left anterior descending artery looks the same as it did after her stents were put in. It's wide open, but now I give her a medication called acetylcholine, and this is a vasodilator for almost all of us, that it should open up our blood vessels. This is how our brain tells our heart to bring in more blood flow. And I give her a low dose of it. And instead of opening up, what you see is this severe constriction, both before her stents and then after the stents. And the stented part can't really constrict, and so that looks like it stays open, but the rest of the blood vessel completely narrows down. I give her nitroglycerin, and this is the same thing that you would do if you gave somebody nitroglycerin under their tongue. And now the blood vessels wide open again. And so when I'm doing this testing, and she has this narrowing, it reproduces the exact same chest pain that had been plaguing her for 12 years. And it, to her, this is what feels like a heart attack. Her EKG becomes abnormal and she has ST elevation. And then I give her nitroglycerin and the blood vessel vasodilates. So this is diagnostic of coronary vasospasm or Prinzmetal's angina, first described in 1953, with this pathologic narrowing of people's blood vessels. But on the surface, when a patient comes in and tells you that they're having chest pain, they don't tell you I have Prinzmetal's angina. They say I have chest pain, and it's impossible to differentiate whether this is due to obstructive coronary artery disease or to something like this unless we look for it. So I changed her medications around. I stopped a couple of things and I got her on the right therapy for the first time in 12 years. And then this is what she says to me. And this is why I do this. And this is why we talk about it. She writes in, and again, I don't share this to brag, but really to illustrate that you can really make people feel better. What you've done for me and others is truly remarkable. I put this to test skiing. She has no symptoms. She's able to go to bed without the fear of waking up in pain. And she really lives this full and very active life. They travel. She sent pictures of her and her grandkids from Portugal last week, or the week before. And it's rewarding to see this, but this is why we do this and why we should all care about doing better for these patients. So I want to expand this paradigm of ischemic heart disease that we all know. So we focus so much on coronary artery disease or atherosclerosis, which is a serious problem, affects 18 million people in the United States. But we have great tools for diagnosing and treating it. So we have stress tests, CT scans, and cardiac catheterizations, and we can effectively treat people medically with stents or with bypass surgery. But often in the same patients at the same time, they will have things like coronary microvascular dysfunction or microvascular disease, coronary vasospasm, and myocardial bridging. And so these are disorders of coronary vasomotion where the blood vessels restrict blood flow to the heart. Patients will present with the same exact symptoms. And we're increasingly recognizing them with new diagnostic tests. The overall population prevalence of all of these is unknown because we only know that patients have them if we test for them. And when identified, we can effectively treat people with medications and lifestyle changes. So this is my next main point. Chest pain in the absence of coronary artery disease is common. If you go back 50 years, if you go to the 1979 seminal paper in the New England Journal of Medicine that established pretest probabilities, and this is what we use when we risk assess patients. We say they're either low pretest probability, intermediate, or high pretest probability to inform downstream decision making. Diamond, Forrester criteria, these stratified patients based on symptoms. George Diamond has this paper from 1979, predating this one, where they describe this paradigm of typical angina, which is effort-related, relieved with nitroglycerin, and then atypical angina, which may only have one of those elements, and then non-anginal chest pain, which has none of those elements. And so in patients, let's start with men and women that have typical angina. And so a man who's 60 to 69 years old with typical angina has a 94% pretest probability of having obstructive coronary artery disease. And then as you go down, you'll see the disparities that start to come out. A woman who has typical angina, who's 40 to 49 years old, only has a 50% chance of having obstructive coronary artery disease. And obviously in 1979, they didn't know what these patients had or really talk about it that was giving them typical angina. But this was a population that was noticed, 50 years ago that really was not studied until more recently. And then when you go down to atypical symptoms, so not having those three criteria that we talked about, women who have atypical symptoms, as we call it, and we're trying to get away from that term because it's pejorative in a way, but it's a coin flip, even at age 60 to 69, and as you go down, it gets less and less. So a woman who's 40 to 49 who's described as having atypical symptoms has more than an 80% chance of having some other disorder that's not coronary artery disease, but these are not things that we look for in earnest. More recently, if you look at contemporary data, this is a paper from the New England Journal of Medicine that looked at the National Cardiovascular Data Registry from the American College of Cardiology. They looked at 664 hospitals or 400,000 patients, and they described the prevalence of obstructive coronary artery disease in people undergoing coronary angiography. So of people referred to the cath lab, and they excluded people who were having preoperative testing, had known coronary artery disease, or had prior CABG. 59% of patients didn't have any stenosis greater than 50%, and only 38% had a stenosis greater than 70%. And that was barely affected by stress testing or the symptoms that they had. And so the majority of people that we're doing diagnostic angiograms on in the cath lab will not have obstructive coronary artery disease, but yet patients fall back on the cath lab as kind of the end site of their diagnostic testing when they have chest pain syndromes. Very recently, the discharge study was published in the New England Journal of Medicine, and this was actually very relevant to emergency medicine. So 3,500 patients and 56% women with intermediate pretest probability who had stable chest pain, either going to the ER or for office evaluations. So these were not acute coronary syndromes. And they randomized patients to either coronary CT angiography or invasive coronary angiography. So all the patients were upfront described as having intermediate pretest probability. And so the prevalence of obstructive coronary artery disease was greater than 50%, was only 26% by either test modality. So 75% of people that were looked at with intermediate pretest probability did not have obstructive coronary artery disease. And so you could argue that they should have been described as low pretest probability, but that you can't edit that after the fact. We kind of have our frameworks for establishing risk. And in real world practice, when you actually go and look, the majority of people going in for evaluation will not have obstructive disease. In the discharge study, revascularization procedures only occurred in 14% in the CTA group and 18% in the invasive coronary angiography group. And so most of these patients had disease that could have been treated medically. And in the discharge summary, they did not try to identify why patients were having these symptoms. So I want to expand this framework of ischemic heart disease and break it down and introduce some new terms. So if we talk about stable ischemic heart disease, we talk about obstructive coronary artery disease. And as a cardiologist, that's what we do in the office. We see patients who have symptoms. We talk about whether they want to do a stress test and ways that we can medically treat them or refer them for invasive coronary angiography. The other side of stable ischemic heart disease is INOCA or UNOCA with an A. So the I is ischemia, the A is angina. And so that's angina and non-obstructive coronary arteries. And so people who have these same symptoms without having obstructive coronary disease. And INOCA is due to microvascular disease, vasospasm, or myocardial bridging. And then we have patients who present with acute coronary syndromes. And so those are unstable angina, non-ST segment elevation MIs, and then STEMIs. The other side of that is MINOCA. And so somewhere around 15% of these acute coronary syndromes could present without obstructive disease. And that can be due to plaque erosion, cardiomyopathies, and coronary vasospasm. And so this framework rounds out these terms that we're used to with obstructive coronary disease and the other terms for acute coronary syndromes, but includes patients who have no obstructive coronary disease. These are a couple of myths. And so the first is that INOCA is benign. And I want to emphatically say it's not, that patients with INOCA may be more symptomatic than those with obstructive coronary artery disease. The prognosis may be worse. And then if you look at Seattle Angina Questionnaire summary scores, which is really our best patient-reported outcome measure for angina burden, the ischemia trial randomized people with high or intermediate burden of ischemia on stress testing to conservative management or invasive therapies. Open CTO looked at people with coronary chronic total occlusions, and then CORMICA looked at non-obstructive coronaries. The symptom burden was highest in CORMICA, and so the lower the score is worse. And so the patients who are the most symptomatic are the ones who have non-obstructive coronary arteries. And then MINOCA is also not benign. People who present with MIs and don't have obstructive coronary disease, they have a high rate of adverse cardiac events. And so it's nearing that of obstructive coronary disease, depending on which study you look at. And so definitely more than 10% of heart events, including death at 5 years. So it's important to remember that somebody has a MINOCA presentation, they go to the cath lab, their coronaries are open, they come back with an MI, fatal heart attacks can happen in the absence of coronary stenosis. All of this said about prevalences and pretest probabilities, this is where disparities come from. And we talk about things like implicit bias and the way we evaluate patients, but it's nobody's fault when this happens. But this is how disparities come about, is that we look at patients, they have symptoms, then because of our prior experience treating them, we say, well, your symptoms don't really sound typical and your baseline characteristics aren't right. And so maybe this is not real. And so this is what happens. And if you look at, I'll show a couple of these studies, one from Australia looking at 54,000 women who went to the ER with chest pain syndromes. Women really suffer from this. Women are more likely to have coronary disease. And as a result, they are less likely to be triaged for emergent assessment, less likely to have cardiac biomarkers checked, less likely to be put into dedicated cardiac units. And then they also have a hazard of dying because of these disparities. This is also true in the United States, looking at the National Hospital Ambulatory Medical Care Survey, 2,300 women. Again, women are less likely to be triaged as emergent, wait longer to be seen, less likely to have an EKG, and less likely to be prescribed cardiac medications. And the patient example that I showed, Laura, really speaks to that she clearly had cardiac disease, but on her initial presentation was told that it must have been something that she ate, because it's hard to believe, especially when people otherwise appear well, that there's something wrong with their heart. So I'll move on to the next section of this talk, which is how can we improve the way that we diagnose and treat ischemic heart disease, and talking about innovations. So if our standard diagnostic approach to ischemic heart disease is that we take patients and we do EKGs, lab tests like troponin, we have stress tests, and then we have cardiac catheterizations. This is really the bulk of what we do. And if we can't figure out the answer for a patient, what do? We just repeat the process. And this cycle is really a burden for a lot of patients, that they jump on this wheel and they can't get off if we don't know what's happening with them. And so to really understand what else we can offer these patients, we have to take a closer look at the heart. And we focus so much on these big blood vessels, the epicardial coronary arteries, that we forget that the heart is really a complex organ in the way that the muscle gets blood. And so we see this rich network of microvascular vessels, which really makes up the majority of vessels in the heart and controls the majority of the resistance. So we focus a lot on putting stents into these big blood vessels, but the predominant tool to regulate blood flow is in the microvascular bed. This system is also under a number of neurohormonal and other controls to increase blood flow. And so there's metabolic factors, there's paracrine factors, et cetera, that dictate how much blood flow we get. And from the day we're born, we know this conceptually, that if you want to go run up a flight of stairs, we take it for granted that your heart can pull in enough blood to pump more blood to your arms and legs so you can do the activities that you want to do. But this system, if it goes awry in any way, can cause symptoms. And that's what we see in these patients with coronary vasomotor disorders. Some seminal work that was done by people like Amir Lerman at the Mayo Clinic and then Cedars-Sinai described novel ways to actually assess patients. And so clinically, we can actually figure out what patients have. So in 1999, the WISE study, the Women's Ischemia Syndromes Evaluation, described coronary function testing as a tool that we can do invasively to actually understand what's happening with patients. And so this concept of abnormal coronary vasomotion, things like coronary vasospasm or microvascular dysfunction, when diagnosed, is associated with a worse prognosis, including ongoing symptoms. But we know that we can do testing to actually explain what's going on with the patients and then give them a diagnosis. And so the work that I do wouldn't have been possible without this foundational work, and it's really a testament to how far we've come. So this coronary function testing procedure, where we expand on cardiac catheterization, we take patients with a suspected ischemic heart disease, and then we do the testing that you saw before. So acetylcholine testing for coronary vasospasm, and then guide wire testing, where we actually measure the hemodynamic significance of plaque in the blood vessel and can also assess their microvascular bed. With this testing, which we can do routinely, we can do this in an hour, often from radial access. It's something that we can scale to hospitals all around the country, and this is what we're actively living through. That now we can give patients these precision diagnoses to better understand why they keep coming back. This is from a state-of-the-art review that we published last year, but you can see that with this 1 hour of testing, we can actually really understand on a basic level what's happening to the patient. We have diagnostic criteria for all of these. But when we can bucket patients, we can actually figure out how to treat them, and then we can speak the common language of what's going on. So if somebody comes into the ER with ongoing symptoms, we can tell you, cath lab, why don't we try a calcium channel blocker, because that might be the right treatment for them. So if we want to give patients an accurate diagnosis, here are some of the diagnoses that we use to describe them. Coronary microvascular disease or microvascular dysfunction, vasospastic angina or coronary vasospasm. We have patients that may have diffuse physiologically significant coronary artery disease. So these are patients without a focal obstruction, but may have ongoing symptoms from plaque that's not readily apparent on the angiogram because it's diffuse, affecting the entire blood vessel. Myocardial bridges are problems where the epicardial vessels tunnel under muscle, and patients can have symptoms from that. Endothelial dysfunction, and a lot of seminal work about this has come out of the Mayo Clinic. And then there's other disorders, things like elevated resting flow or abnormal nociception, and all of these can contribute to symptoms in patients who have no obstructive coronary artery disease. There have been recent randomized trials like CORMICA and CHAMP-CMD that have demonstrated that patients have improved symptoms and improved quality of life if we base medical therapy on a precision diagnosis. So rather than saying somebody came to the ER with chest pain, put them on a beta blocker, put them on a long-acting nitrate, we should actually think about what they have and then focus our treatment on those patients. So in the last part, I want to talk about some of the work that we're doing at Yale to move forward in this field. So I'll start with this slide that this is from a monograph by J. Willis Hurst, who's really was a huge cardiologist in the history of United States cardiology. He wrote this monograph called Chest Pain, which I found on eBay many years ago. So he writes this in the preface. We hear words such as atypical chest pain and non-cardiac chest pain as the final diagnosis of patients who have been subjected to several high-tech procedures. Patients know that these words are not diagnoses, as do referring physicians who send their patients for the high-tech procedures. These designations and the lack of resolution renders therapy impossible. Accordingly, the patient's problem remains incompletely addressed, unresolved, and unrelieved. So my first thing that I want to show you is to answer this question: what can we learn from our patients? And so this was a study funded by the FDA through the Yale Mayo Clinic Centers of Excellence for Regulatory Science and Innovation, or CIRSE mechanism. And so this was really a great opportunity for me to learn more about regulatory work. So we did something called a concept elicitation study. Our medical student who worked on this and did her thesis called this Unheard Voices. And so we interviewed 50 women with INOCA, and it was 35 hours of interviews. We coded the interview transcripts for common themes, and we identified domains and key concepts. And we specifically talked about symptoms that patients were having, the physical toll of their symptoms, the functional limitation, the patient's perception of their illness, and then the psychological toll of their disease. And the goal of doing all of this is so we can actually come up with a patient-reported outcome measure, so we have a standardized language, so we know where patients are in their symptom trajectory, and we have actually formal ways of assessing patients. I want to show you some excerpts from these interviews. And so the first is a patient who was described as having atypical chest pain, and she had a kind of a sentinel presentation, had ongoing symptoms, and then was readmitted, and then eventually we were able to give her the right diagnosis. But this is how she came in. And then if you look, once we do a catheterization on somebody and we see non-obstructive disease, we start describing atypical chest pain. But this is her initial presentation.
Sure. And was walking down the hall, and I just, my heart was pounding. I was having trouble breathing. I'm thinking, I'm out of shape. I got into the next room. By the time I got into the next room, I had this pain, like this pain pressure in my chest. I started sweating profusely. I started shaking. The pain was going across my back, down my arms. And I was like, something's wrong here. This is not just me being out of shape or whatever. So I called.
And so that's a patient who she called her husband and she drove herself to the hospital. But you have to think about these patients in context. And so when they come in and they're otherwise physically well appearing and they don't have traditional cardiovascular risk factors, it's easy to come up with other answers for why they might have these symptoms. But these INOCA syndromes it's like chasing a ghost. There's nobody, the patients don't have a sign that say, I have a myocardial bridge. I need more, more evaluation. This is another patient who had had a couple of ER visits, and then she kind of got tired of going to the ER. And so this is what she said.
But the symptoms were like a heart attack to me at the time. Yeah, so chest pain and difficulty breathing. And I felt like I was dying. So I went to ER. That's how it started.
And so both of these examples, when we hear these patients and you take them out of the context of being in the emergency department, these are distressed patients and they really have very valid and real symptoms. And so this is what kind of inspires us to do the work that we're doing. So if we were to take those interviews and we distilled them down, and this is a manuscript that's pending, if you look at their symptoms, this is what of the 50 women that we interviewed, who have 9% of them described chest pain, 86% had shortness of breath, 86% had radiation of their chest pain to their jaw, to their arm, to their back, or other non-chest regions. 80% of them also had fatigue. And then there's these other symptoms that even as a cardiologist, I kind of said, it's impossible to know. But really, a lot of these patients said this. They had a sensation of abnormal heartbeats, or not quite palpitations, but some sort of fluttering in their chest. 50% of them had what we would call GI symptoms like nausea or heartburn. 50% of them had lightheadedness, and then 24% had diaphoresis. The other part of this that I want to show you is the psychological toll. So a lot of these patients had anxiety, but related to their symptoms. And so if somebody doesn't already have an anxiety disorder, it's hard to bill them as being anxious when really they're anxious because they feel like they're having a heart attack. Patients also had, they were discouraged, they had frustration. And then these last two are really key. So invalidation was reported by 66% of the patients, and then dismissal from care was reported by 80% of patients. And this is sobering to all of us, I think, when we go to work and we want to do our best for our patients, and we never try to do this. But these dynamic syndromes are so challenging to diagnose that invariably this is what happens as patients get falsely reassured despite ongoing symptoms. And then finally, if you look at what happens to a patient, so if we were to distill this down into two phases, prior to having a diagnosis and after having a diagnosis. So before they have a diagnosis, they had few effective management options. And then after diagnosis, they reported that they were able to take medical therapy. They had a better understanding of their illness and fewer and less severe symptoms. Prior to their diagnosis, they had a lack of knowledge about effective lifestyle changes. And then after, they had better knowledge of lifestyle changes, including exercise and stress reduction. And then prior to diagnosis, they had feelings of invalidation by loved ones and providers regarding symptoms and experiences. I will always remember the patients who kind of look at their spouse and say, I told you it was real. And then after having a diagnosis, they have improved mental health and less anxiety about symptoms and more confidence seeking care. So the next question is, this is one that I think comes inherently to emergency medicine, is can we use biomarkers in the ER to differentiate patients? So can't we use a troponin to say this patient has obstructive disease or this patient will not have obstructive disease? And even though troponin is best validated for a rule out, and this is really done amazingly well in emergency departments where you use a high sensitivity troponin and can appropriately risk stratify a patient. When the troponin is positive, we start to use it as a rule in. So let's test this. And so this was actually inspired by one of our medical residents who posed this question to me. So can we use high sensitivity troponin as a rule in for obstructive coronary artery disease? So we looked at 1,026 patients who came to the ER at Yale, had a high sensitivity troponin checked, and then went to the cardiac cath lab. We excluded patients with STEMIs, cardiac arrests, and cardiomyopathies. And so that left us with 728 patients. The mean age was 68, and the cohort was 62.5% male. Here's what we found. So overall, of these 1,000 patients, and this was basically for a full calendar year, 43% of them had no obstructive coronary artery disease, despite following this trajectory of coming in, having an elevated troponin, and going to the cath lab. And so this is really a much larger number than we would have suspected up front. Of the people who had no obstructive coronary artery disease, 56% were female and 35%, of all females, 56% of females had no obstructive coronary artery disease, and of all males, 35% had no obstructive coronary artery disease. So again, the majority of female patients who had ER presentations, high sensitivity troponin, and went to the cath lab did not have obstructive disease. The delta change in the high sensitivity troponin did not predict obstructive coronary artery disease. Which was this was kind of a big finding for us because we thought that an escalating delta would be more likely to have obstructive disease, but that is not true. If you add in stress testing or heart scores, again, that did not increase your prediction of coronary artery disease. And so, again, all of these tools are best for rule outs, but ruling in obstructive disease is a lot harder. So the only predictors we found are the things that we already know. Male, white race, and hypertension were all predictors of obstructive coronary artery disease. And then after all of this, we can kind of confidently say that you cannot use a troponin to be the arbiter of whether somebody has real disease or not, because the clinical syndrome is what's going to dictate what they have.
Dr. Shah, can we have your opinion on if the troponins are negative or normal and there's no delta, does that rule out the disease?
It rules out an acute coronary syndrome, and I think that's where troponin has been best validated, is to say that this patient is safe to go home or be discharged from the ER. Same with heart score. I think this is how you kind of risk stratify who can go home or not. But that doesn't mean it's not cardiac. It doesn't mean that it's not coronary artery disease. But it just means that they can safely be discharged and they should have close outpatient follow-up, especially if they have ongoing symptoms.
Thank you.
So then the next study I'll move on to is what's the utility of coronary function testing in real world practice? So I described this fancy testing that we do in the cath lab, but does it actually matter? Does it actually benefit patients? And so this was a study that was funded by Women's Health Research at Yale, and that's been an instrumental driver of my career, that I got pilot project funding on my second year as faculty, which has led to much bigger projects. So this is what we looked at. We looked at coronary angiography versus coronary function testing in women. So we took 99 women who had angiography alone, 99 women who had coronary function testing, including those other tests that I had described. This is all of this at the same hospital. This is really the same patient population, but it's just different types of testing. And we looked at what the post-procedure diagnosis was, and then changes in medications at 24 hours and 30 days. Demographically, the patients were similar. So in the angiography alone group, patients were 62 years old. In the coronary function testing group, they were a little bit younger. Otherwise, their baseline characteristics were largely similar. Comorbidities is really fascinating. So the angiography alone group, a lot of them had hypertension, hyperlipidemia, same with the coronary function testing group. And then if you look at stress testing, angiography alone, these patients had a high prevalence of having stress tests performed at all, and then also a high prevalence of ischemia on their stress tests. And so both of these groups have no obstructive disease, but I'll kind of show you what they ended up looking like. So these are the key findings of this study. So coronary angiography alone, we talked about their baseline factors. 21% of them had normal coronary arteries and 79% had non-obstructive coronary artery disease, which is how we describe patients who have just kind of luminal irregularities or something like that without a stenosis. The physiologic diagnosis was none, because these patients only had an anatomic test to look at their epicardial vessels. And then medication changes, so 41% at 24 hours, and this was usually statins or preventative therapy, and then further medications were 30% at 30 days. On the other hand, the people who underwent coronary function testing, 48% were found to have normal coronary arteries, 52% had non-obstructive disease. All of these patients had a physiologic diagnosis, so 20% had microvascular disease, 32% had vasospasm, 16% had a mixed disorder, and 4% had symptomatic myocardial bridging. So these patients in the first group may have had these, but they weren't tested for them. And then there's more intense medication changes, because once you know what the diagnosis is, and the person who's seeing the patient in follow-up is able to actually treat them. And so 65% had a medication change in 24 hours, and an additional 44% at 30 days. Really dial down at what those medication differences were. Anti-anginal therapy was titrated in the overwhelming majority of people who had coronary function testing, and so significantly more than the coronary angiography alone group. And specifically, calcium channel blockers were much more likely to be used. And so you get a difference in treatment actually once you do coronary function testing, likely because you're unearthing diagnoses like vasospasm or endothelial dysfunction, which you otherwise wouldn't see if you just stopped by sending them to the cath lab and doing a routine coronary angiogram. And so the last part is our best chance of having real world evidence. So this is my pride and joy. So the determining the cause of coronary vascular disorders in patients with ischemia and non-obstructive coronary arteries, discover INOCA prospective multi-center registry. Amir Rahman at the Mayo Clinic is on our executive committee for this. This has been in the works for over 4 years now, and so we're actively enrolling and have about 160 patients enrolled. So Discover INOCA is a multi-center registry. We're enrolling at 10 United States centers, and we're taking patients who come into the cath lab and they're undergoing invasive coronary function testing. So all patients are just enrolled because they have suspected ischemic heart disease, and then the testing is dependent on the operator. So the objectives of Discover INOCA are to describe the prevalence of INOCA, so we can all speak the same language and we can say, actually, yes, you had a normal CTA, and patients who have ongoing symptoms, 30% of them will have microvascular disease or vasospasm, et cetera. Then we want to characterize the burden of epicardial atherosclerosis and myocardial bridging. And so we do this both by angiography and then intravascular imaging on all of these patients, which is really a unique feature that we don't typically image all of these patients. The reason for doing this is that we need to know what their plaque characteristics are, because if I'm telling you about prognosis of coronary vasomotor disorders, we need to understand how much plaque they have and if they have high-risk plaque characteristics, because that may actually be more important to their long-term outcome. And then finally, we want to define the hard outcomes and the patient-reported outcomes. And so I want to be able to tell you next time I come back from Mayo Clinic Emergency Medicine Grand Rounds that these patients with vasospasm have a X% risk of heart attacks or death, because right now this is really a black box for us. The inclusion criteria for Discover INOCA are patients with suspected ischemic heart disease who are referred for coronary angiography. You all have taken care of these patients who come in and then end up going to the cath lab. And then we make sure that the patients have no obstructive disease, both anatomically and physiologically. We exclude people with MIs within 90 days. And so we're looking at INOCA, not MINOCA. And we exclude people with prior stents, mainly because stents have their own hazard of long-term outcomes, and we want to make this clearly a definitive study for this patient population. This is what our study assessments look like. So we do baseline patient-reported outcome measures, and then we do them at all serial assessments. They have their coronary function testing, as I described, and we try to give them a diagnosis up front, which that's kind of how we categorize them. And then we look at their medications and changes in their medications over time. So we have a centralized call center actually following up on all of the patients who are enrolled. And so it's already become a massive data set, but really we want to shed a lot of light on this patient population. Some initial results. So if you look at the patients that we've studied so far, 20% of them have a history of coronary artery disease. The average age is 57. Of the patients we've enrolled, 79% are female and 21% are male. This is really a remarkable demographic breakdown for a trial in interventional cardiology, but this is a disease that it follows these demographics, and so that's why we're trying to have a representative study. And the same is true of racial and ethnic differences. We actually did a study protocol update to include non-English speaking patients, because with a central call center, it's a challenging feat, but we thought it was important to make sure we include those patients. The way that patients presented, 53% had stable symptoms, and then 47% were billed as having unstable angina. Often these were patients who were recently in the emergency department or admitted to the hospital from the emergency department. We categorize patients based on their Canadian Cardiovascular Society angina classification, and so we can kind of get some sense, and this is a crude sense of how bad their symptoms are, and then Braunwald unstable angina classification. And so up front, the majority of patients had moderate intensity symptoms, and I'll show you a closer look at that in a second. And this follows kind of some of the previous work that I showed you locally, but now this is a multi-center study. So of the patients enrolled in Discover INOCA, 45% have normal coronary arteries and 55% have non-obstructive coronary artery disease, or a stenosis less than 70% by anatomic criteria. Then if you look at their physiologic diagnoses, 23% had microvascular dysfunction, 46% had vasospasm, 16% had a mixed syndrome, and then 22% had other, which included symptomatic myocardial bridging. And then 10% of patients had normal physiology, which is actually a great bucket of diagnoses for us because it creates a benchmark of patients who made it to the cath lab, had all of this testing done, and we couldn't find something wrong with their heart. So they may have had, some other cause of their chest pain, but we can at least, have a comparison within our cohort. Overall, we changed their diagnosis 91% of the time when we did coronary function testing. And so if you go from pre-procedure diagnosis to post-procedure, we're able to use precision testing to give them a diagnosis. And then medication changes occurred in 76% of patients. The symptoms that patients reported, and so we talked about this from that FDA-funded study, but this is kind of and then they used other terms as well. And we spend a lot of time talking about this, that some, a patient may say, I don't have pain, but they have pressure, they have tightness. And so these abnormal chest symptoms. And then patients also had shortness of breath, fatigue. Interestingly, this was a notable sex difference that females were more likely to have arm, neck, and jaw pain compared to males. And so already we're starting to see these differences in symptom reports come out. And then triggers of symptoms included exertional symptoms, emotional stress, resting symptoms, which was actually very highly prevalent, that these patients who had vasomotor disorders often have resting symptoms. And then the Seattle Angina Questionnaire element scores and summary scores are here. The main thing I want to show you, this is a lot of graphs, but on the summary score down here in the bottom right, these are really low summary scores to start with. And this is kind of what I showed you before when I was talking about symptom burden in INOCA, that these are incredibly symptomatic patients. But just by giving them a diagnosis and making those early medication changes, you start to see symptoms improve. And the Seattle Angina Questionnaire summary scores come up a very significant amount. These are all statistically significant at all of the follow-up time points. And it shows that even in a registry design, we're not dictating therapy. People are doing this at their own individual centers. You can effectively make people feel better if you know what they have. And so we're going beyond somebody who just has normal coronaries or non-obstructive disease and squirrely symptoms to actually treating them for what they have. And we're seeing symptom improvement. So there's more to come from Discover INOCA as we continue to enroll, but I wanted to give you this snapshot of the work that we're doing. And so this is the last part of this talk. And so I'm going to go back to my title, which is Seeing the Invisible. And so I've told you a lot about what we're doing, why we're doing it, but I want to show you how we're putting this work to practice. So this is a patient that just came in last month. And so we're coming full circle. 37-year-old woman has a history of hypertension, comes in with left-sided chest pain that radiates to the jaw and the left arm. I think your ER nursing notes might look like this in Epic, but this is where the truth comes from, is the nursing notes. And so here's what we see. 7:16 a.m. Patient with chest pain, history of hypertension, received aspirin, reports pain is better, denies any current symptoms. 8:06 a.m. Returns from X-ray reporting increased pain, 8 out of 10, MD aware at bedside, patient medicated per orders. 8:23 a.m. Patient with pain resolution status post nitro, cardiology at bedside. 8:44, cardiology fellow cancels a cath lab activation, which you're always frustrated by. We get it. But then you were right in this one. So here's what happened. So 8:59, she has worsening chest pain, crying, appears uncomfortable, EKG done. She's given a second dose of nitro. Cardiology is back at the bedside. The fellow has to eat his words. And then now the patient goes to the cath lab. So here's what her EKG looks like. So this is her baseline EKG 5 years ago. And then this is her EKG when she comes in. So now she has these really pathologic ST depressions. She has AVR elevation. So this is, a concerning EKG when somebody's having active chest pain, they're in distress, they're crying. And so it makes sense that they need an urgent evaluation. So this was her EKG when they activated the cath lab, that second time point after the fellow had canceled the first one, which now these ST depressions are deeper, AVR elevation. And so this is clearly an ischemic EKG. I think, you would all agree, as cardiologists, we would all agree. I don't think anybody would downplay this and say we can sit on this EKG when somebody's having chest pain. So she goes to the cath lab. This first picture is of her right coronary artery. Second picture is of her left coronary system. This is the catheter here, the left main, and then the circumflex is coming down the middle. It's essentially free of disease. This is the LAD in the proximal part of it at the top. And then a couple more views. So here's her LAD. And then all the way down at the bottom, it narrows a little bit, and I'll show you that in this other view. So this is the LAD again. Down here at the bottom, it really narrows down to like a thread, and you see that. Play that. So here's what they write in the chart, and this is the cath report. They write severe distal LAD disease, medical therapy, heparin drip for 24 hours, and dual antiplatelet therapy. Consider a vasculitis workup. So she goes upstairs to the floor. She's admitted to the cardiology service. And so they consider diagnoses like spontaneous coronary artery dissection. They think about vasculitides, which are admittedly rare in coronary arteries. And then they said, maybe this is just atherosclerosis of her apical LAD. But while she's in the hospital, she keeps having these episodes of chest pain. And so with awareness and as a result of the work we've done over the last 8 years, they said, look, we have the resources. We might as well just send her back down and figure out what's going on. And you always hate to put somebody through a second procedure, especially when they're 37. But in this case, it's an opportunity to prevent what you saw in the first patient that I showed, that we can kind of nip this in the bud. So we bring her back down to the cath lab. And then this is now what we call a guide catheter. We take our baseline pictures, and that narrowing that you saw in the apex is now gone. That's resolved spontaneously. And so this is not vasculitis. It's not SCAD. And so now we have to wonder what this is. So we just go through the standard set of testing that we do. So now when I give her acetylcholine, her LAD basically disappears. I give her nitroglycerin, and here it comes back. I had crushing chest pain while I was doing it, and I quickly aborted that with the nitroglycerin. She felt better right away. And then I move on and I do microvascular testing. I'm not going to spend a ton of time on this screen, but this is kind of a snapshot of what our hemodynamics look like. When we're measuring the physiology in the blood vessel, we can measure the pressure differential across the entire blood vessel. We do what we call thermodilution to actually estimate flow. And then between flow and pressure, we can derive resistance. And so we can definitively tell you this patient does not have microvascular disease. And so we don't have to presume that that's what she has. We know. So if she has ongoing symptoms, we know clearly what her diagnosis is and what it isn't. So then we diagnose her with coronary vasospasm, just like that first case that I showed you. This is her EKG when she left the hospital, so completely normalizes from what I showed you before. She was started on high-dose calcium channel blockers, and it's been really satisfying to see that she's been asymptomatic now in follow-up, and her biggest struggle has been establishing care with a cardiologist because she's 37 and she didn't have one, and so now we're plugging her in and getting her seen. So this is a very different course than the first patient that I showed you, where we didn't have these tools available, and so she went 12 years with ongoing symptoms before she got a diagnosis. I would love to take your questions, and so my concluding statements are, INOCA is increasingly recognized, and coronary function testing can be used to give patients a clear diagnosis. Patients who present to the emergency department with new or persistent cardiovascular symptoms likely have a cardiovascular diagnosis. And it's only if you have a different diagnosis that explains their symptoms that we can, that we can then say it's not cardiac. But it should be cardiac until really, truly proven otherwise. And then this is a patient population that's highly symptomatic, at risk for repeat presentations, and may be difficult to identify. I wish patients had t-shirts that told us what they have, but these are really invisible diagnoses until we take a look. And so it's important to keep an eye out and to not falsely reassure patients if we don't know what's going on. And then we're trying to better understand the long-term hazard of INOCA with Discover INOCA, and we're looking forward to sharing more of those results with you in the next few years. So thanks for this opportunity, and I would love to take your questions.
Thank you so much, Dr. Shah. That was outstanding. There were a few questions that I have collated, but first, are there anyone who wants to unmute and ask your question directly? Well, feel free to interrupt if you do. The questions that came my way here, let's see here. Can any of this be evaluated with any specialized CT or MR?
Yeah, so it depends on what center you're at. And so not every patient needs a procedure. And I would say that of the patients that I see in the office, I don't send the majority of them in for testing, that we try to empirically medically manage them, or we use testing. So the types of non-invasive testing that you can use, a CT angiogram is actually a very powerful tool to avoid an invasive test. So somebody comes in, they, like you said before in your prior question, Dr. Bellamconda, that they have 2 negative troponins, they're otherwise low pretest probability or low risk. You can discharge that patient and get a coronary CT angiogram, and then you know that what we're talking about must be either a vasomotor disorder or some non-cardiac syndrome. But let's start with a vasomotor disorder. So then you can either empirically treat the patient, and you could say, let's focus on a diagnosis, microvascular or vasospasm, and specifically target that diagnosis. But if you want more information, you can do things like a cardiac MRI. So some facilities can do a phase contrast MRI and calculate a myocardial flow reserve from the MRI. And that's an assessment for microvascular disease. At Yale, we're a very positron emission tomography, or PET, myocardial imaging facility. And so we would do a PET stress test to look at their myocardial flow reserve. And that, again, would give us the same information. So I tell patients, if you're an outpatient and you're having tests done, a coronary CT angiogram and then a PET stress test, and often insurance companies won't go for both of those. But if you're in the ER, you've had a CTA and now you need another test, I think it's helpful to have a functional test to try to understand what the patient has. So now let's say your test result is negative. I think you're still left with whether you want to empirically treat that patient or give them nitroglycerin to take home, because that may resolve their symptoms, at least until we can give them an answer.
That makes sense. A personal add-on to that, do you see any role in the future of intracoronary ultrasound in your research? Would that add anything to your diagnostic workup?
So we do intracoronary ultrasound routinely when we do stents, and it's something that we know actually improves long-term outcomes. And if you look at meta-analyses, actually may improve long-term mortality for stents. Discover INOCA is the first study where we're doing this in non-obstructed vessels routinely. And so so what we found, and I can't wait to be able to report these results, is that a ton of these patients that we describe as having minimal plaque or no plaque have very high risk plaques or thin cap fibroatheromas, things that put them at risk for MIs. And it's a patient population that has a lot to gain from primary prevention. And so it's important to identify those things early on so we can put them on statins or other medications to reduce their long-term risk.
Very helpful. And another question that came through, it's more of a summary / make sure we understood it right. So they say, basically, to be better on our next shift, are we saying really we should be aware that a positive troponin doesn't always mean there's obstructive disease? And secondarily, if our evaluation in the ED is benign, really we should be focusing on validating that the symptoms are still important and there could be potential need for further investigation of other cardiac syndromes. Is that the right takeaway here?
Yeah, I would love it if that was your takeaway. I would say that I did my job. I think that's great. And Mayo Clinic it's been such an instrumental place for this disease and this type of testing that patients from around the country will go to the Mayo Clinic to have this testing done. And so remember that you have better access to this than a lot of other centers. And so if I think validating a patient rarely hurts to say, yeah, it could be cardiac, and you're in a place where we can get you the right care. So I think that's such an important takeaway, and I actually feel very heartened that that comment came through.
I have more, but Dr. Johnson has her hand up, so let's go to her.
Thank you for this talk. This is awesome. I'm just wondering, sorry, I'm echoing. I'll step outside the room. I'm just wondering, I'm from a rural area, and I'm just always curious, like, what would be your indications when you would definitively refer this patient for advanced imaging from the emergency department? And in the interval, as they remain symptomatic, are things like sublingual nitro, or like you said, the high dose calcium channel blockers? Are there any other empiric therapies that you could kind of trial for these people almost as a theranostic leading into those appointments, and that have low risk but high benefit that could help this population, I guess, ultimately?
Yeah, thanks. That's a great question, Dr. Johnson. And so, so I think using the same strategy, and I grew up in a rural town, and so I understand that. But I see patients who have had multiple procedures. I see them on a referral basis, and so they've already kind of been through a lot. So we try to take a minimalist approach. And so if we were to use the resources available, if you have a cardiac a coronary CT angiogram available to you, that to me is the highest yield test, because the number one question when patients have these symptoms is, am I going to drop dead of a heart attack? And so that's the best way that you can reassure somebody that they don't have like a 95% LAD or something like that. So there may be something wrong with their heart, but that's not what we're worried about. So if you can do a CT angiogram, that's probably the number one highest yield test. And then in terms of empiric medical therapy, I think sublingual nitro alone is a great thing to give somebody no matter what they have. And then, we're still trying to figure out what exactly the symptoms are for each syndrome. But if we said, like, let's look at the typical descriptions or what's already out there. Coronary vasospasm is often nocturnal. It can be chest pain that happens at rest. It can be sporadic. There's no clear trigger to it. And so if somebody has that symptom cadence, then yeah, I think high-dose calcium channel blockers, verapamil happens to be my drug of choice, but different centers use different drugs. And then sublingual nitro as needed would be an effective regimen. For microvascular disease, and a lot of this has come out of Mayo Clinic, that you can use beta blockers with escalating doses. I use cardiac rehab a lot, which I think, if it's available, is often a good tool, or just structured exercise if patients understand that they don't have to stop when they feel symptoms, that they can gradually try to work through it. That often makes people feel better in the long term. There's a lot that's being written about potential treatment pathways, but again, not every patient wants to be on 4 or 5 drugs. So it's important to think about what they might have. And then to your point, just use the treatment as a theranostic, see if they respond to sublingual nitro or a calcium channel blocker. And if it doesn't work, no harm, right? Just say, okay, well, we tried, let's pivot to something else. And then if you hit a wall, that's when that between you and the patient, they may say, okay, yeah, you're right, I'm going to have to go get more testing done, and I'll have to travel, but at least then I'll be able to know what's going on.
Are there other questions from the conference room? Well, there was one other question from the chat. To kind of set the stage, Dr. Shah, it comes from Dr. Carpenter, who's one of our national leaders in emergency medicine, especially works a lot on creating clinical policies and guidelines based on the available evidence. And so he posed the question, he was wondering what pertinent existing EM clinical practice guidelines should do to incorporate this category of diseases or chest pain syndromes. What would you recommend that we incorporate in there? Do you have any follow-up answers for that?
Yeah, thanks so much. And thanks, Dr. Carpenter, for your work in this area. Could I just ask if somebody could email that to me, just because when the chat closes, I'm going to lose that link, but I do want to take a look at what's already there.
Absolutely. I'll take care of it.
If you look at the 2021 American College of Cardiology chest pain guidelines, they used a lot of the messaging that I've talked about today. So discarding that term atypical and using possibly cardiac instead. It's this whole mentality that, even though it doesn't look like a duck, sound like a duck, and walk like a duck, it could actually be a duck. And so possibly cardiac, I think, is a better term because it doesn't dismiss the patient from care. And then The other thing is, it's a two-way recommendation to do coronary function testing in the ACC guidelines. So I don't think you can come in stronger than that in the emergency medicine guidelines. But it may be worth saying that once somebody rules out using biomarkers, that they may still have a cardiovascular syndrome. And so then you can follow the ACC guidelines that if they have persistent symptoms, that may be a patient who may benefit from expert referral to a cardiologist and or further testing.
Excellent. And I'll send that question to you as well, so you'll have it, as well as the link he shared. I only have one other question, and that was going back to the symptoms. You reported that more of the women in your study reported jaw pain, back pain, etc. And this colleague was asking, did they have that in isolation of chest pain and shortness of breath, or was that in addition to chest pain and shortness of breath?
It's either. So this is something that we're trying to tease out with this FDA project to develop a patient-reported outcome measure. It's a continuum. So some people may have isolated jaw pain or chest pain, and I think it's important just to know that a lot of women will come in with jaw pain or pain that radiates. One of the patients that we did vasomotor testing on came to us from ENT because she was referred to the ENT for jaw pain, but it was actually her anginal symptom. And so again, a persistent symptom kept bringing her back. And the one symptom that's very key that we didn't really capture in this is patients will tell you whatever it is, it stops them from what they're doing. So like you can have jaw pain related to your tooth and get through your day, but when it stops you in your tracks and you wake up from sleep or doing something and you have to stop your exertion because of your jaw pain, I think that's a patient where you're going to say maybe this is something bigger or it's their heart.
I think that's a really great summary there. Certainly we can ask more questions, but I know we're a bit over. If anyone else wants to ask questions, please stick around, or you can email me and I'll send them on to Dr. Shah if that's okay with you.
Thanks, everyone.
Thank you so much for the talk. It was wonderful.
Thank you, Dr. Bellamconda. Thanks for the invite and the opportunity.
Okay. Thank you, Dr. Shah. That's a wrap for this chapter of Always On EM. Be sure to come back October 1st, 2024 for the next installment. I'm going to keep this really short to just close out the show. Be sure to like, follow, comment about the show if you could, and thank you for listening.
The Always On EM podcast.
Emergency Medicine Grand Rounds.